Hello my dear friends, welcome to Forensic Medicine by Dr. Paras, and now we are going to discuss chapter number 11 my dear friends. In chapter number 11, number one thing we are going to talk about the skull vault fractures. The different fractures, how to identify them, what are the clinical relation and everything we are going to study right now. So skull vault fracture, number one topic. So in skull vault fracture, there will be a number one fracture, fissure fracture or a linear fracture. So the name itself is telling you linear, that means single fracture line is there. Single fracture line is there. Single fracture line is there. And this is the most common type of skull vault fracture. Single thin line is seen, and mostly we can see this type at the time of autopsy. Mostly we can see this at the time of autopsy only, my dear friends. So if I can show you right here, sir, mostly we can see that at the time of autopsy. Other than that, they are named according to the location. If I write just here for all of you, according to the location, number one is hairline. Number one is hairline fracture. If I talk about the hairline fracture, my dear friends, hairline fracture, it occurs in the vault of skull. If it occurs in the vault of skull, then we call this as hairline fracture. Second name we can call it basilar. Basilar fracture. If this is basilar fracture, guys, remember it occurred in, if it occurred on skull base. Skull base. Third category we are having right here, sir, diastatic fracture, which is also called as diastatic or sutural fracture. Why this is sutural or diastatic fracture, my dear friends? Because fracture line runs along the line of suture. This is first type of fracture, which is a fissure fracture or linear fracture. We have learned this, sir. Now second type of fracture we are having what, sir? It is depressed fracture. Depressed is also called as signature fracture, my dear friend. Depressed fracture or signature fracture. If you can see this fracture, the fracture with a heavy weapon with small striking surface. The best heavy weapon with a small striking surface can be hammer. Yes, this is hammer. Can be axe. This is axe. The striking surface is small. Striking surface, you can see the small, and once it hit the skull vault, you will see the depression right here, sir. You can very well see the depression right here, sir. So this is what called as depressed fracture or signature. The medico-legal importance. Medico-legal importance, that you will come to know the weapon used. Weapon used, you will be clearly coming to know with this, my dear friends. Other than that, this is second most common fracture of the skull vault. This is second most common fracture of the skull vault. The fracture site would be lacerated or having the contusion. Fracture site would be completely lacerated or can have contusion also, but laceration is a correct word. Laceration means there will be a skin, cut in skin, plus bone is gone. Bone is gone. Management, lift the segment. You have to lift whatever the part is depressed now. You have to lift it, lift the segment and repair the dura. Lift the segment and repair the dura. You have to repair the dura mater. This is all about the depressed fracture. Now we coming to the third fracture. Third fracture is comminuted fracture, my dear friends. Comminuted fracture is also called a spider web fracture. Like this is, I can draw spider web. Spider web. This is spider web, my dear friends. Now, multiple fracture lines are intersecting with each other. You can see right here, sir. One fracture line intersecting each other. They are connected to each other. This reading of fracture line, first fracture line, then second fracture line, third fracture line. This is only possible with the multiple attacks on the skull vault, my dear friends. Remember the first line, second line, third line. This is readed with the help of rule called as Puppy's rule. Puppy's rule. Puppy's rule will tell us about the sequence of fracture line. Sequence of the fracture line. First fracture line, second fracture line, third fracture line. With this, we'll come to know the sequence, my dear friends. Now, sutural diastatic is again a linear fracture ka example only. Fracture lines running along the sutural line, my dear friends. Most common suture involved would be the sagittal suture, which is getting closed at the age of 20 to 25 years. The suture is getting closed at the age of 20 to 25 years, my dear friends. Now coming to the next type of fracture, that is Pond's fracture. Pond's, or this is also called as ping pong's fracture, my dear friends. Pond's fracture or ping pong fracture. The fracture of elastic skull. So whose skull is elastic? That is neonate, newborn child, neonate, 0 to 28 days of child, newborn child. The head is very much plastic. On the plastic head, whenever we are applying the forceps, there will be a depression like this. It becomes normal after some time. And if hematoma is there, if hematoma is there, then it can lead to jaundice. Jaundice is there because hemolysis will happen, then bilirubin, and eventually there will be jaundice and baby can die also. Now there will be skull base fractures, my dear friends. In skull base, there will be a number one fracture we are going to study is a ring fracture. If you talk about the ring fracture, it is associated with fall from height. You are falling down from the height. In that scenario, you can encounter with the ring fracture. Fracture line running around the foramen magnum like a ring. So let's see with the help of diagram. This diagram you can see, this is foramen magnum. And this red part is fracture line. And this fracture line is forming the ring. And history associated is fall from height, fall from height, fall from height. Now, is a fracture of posterior cranial fossa. It is a fracture of what, sir? Posterior cranial fossa. Now, type 2 fracture is a hinge fracture or motorcyclist fracture. Hinge fracture or motorcyclist fracture, my dear friends. Fracture line dissects the skull base into two halves. Like if I can show you here, sir, the fracture line is running from the silica turcica and it is dividing the skull vault into two parts. One part, this is A, this is B part, A part, B part. The fracture line is dissecting the skull into the skull base into the two halves, my dear friends. It is a fracture of middle cranial fossa. And with the fracture of middle cranial fossa, your cribriform plate plate is damaged. And because the cribriform plate is damaged, you will see there will be a blood at periorbital area, and this will lead to raccoon eye, which is also called as panda eye. Raccoon eye or panda eye, the hinge fracture or motorcyclist fracture. Now, coming to the intracranial hemorrhage. The next topic what we are going to start is intracranial hemorrhage. And remember guys, brain is divided like this: PA, then you have to remember DS, pads. The mnemonic is pads. Pads mnemonic is there. If I can show you here, at one go, pads is there. Inside what is there, sir? Inside there will be a brain. Inside there will be a brain. If I draw like this, then from inside to outside the structures will be like this: P, that is pia matter, A, arachnoid matter, then D, dura matter, then in the last it will be skull vault. Then in the last it will be skull vault. So how the mnemonic was? According to this, P, A, D, S. This is pia matter, arachnoid, dura, and skull vault. Skull vault. So now we will see the hemorrhages happening between pia matter and the arachnoid matter. Pia and the arachnoid matter. Between this pia and the arachnoid matter, the hemorrhage happening is subarachnoid hemorrhage. Here the arteries are present. Subarachnoid hemorrhage, the arteries are present. Artery present. The between pia matter and arachnoid matter, which type of hemorrhage is happening? Subarachnoid hemorrhage. The clinical symptoms is worst headache of the life. If subarachnoid hemorrhage is there, worst headache or thunderclap headache, the word we will use here is thunderclap headache, or the worst headache of life would happen right here, sir. Other than that, there will be arachnoid matter and the dura matter. Sir, between arachnoid matter and the dura matter, the hemorrhage which is happening is subdural hemorrhage. Subdural hemorrhage. In subdural hemorrhage, there will be injury to the bridging vein. Injury to the bridging vein. Bridging vein injury will be there. Then between dura matter and skull vault, between dura matter and skull vault, there will be a extradural. Yes, there will be a extradural hemorrhage. There will be what, sir? Extradural hemorrhage. Extradural hemorrhage will be there. Extradural hemorrhage, there will be a injury to the middle meningeal artery. There will be injury to the middle meningeal artery. Now let's talk about EDH, SDH, SAH, my dear friends, individually one by one. Individually one by one. If we see the extradural hemorrhage, the hemorrhage between skull vault and the dura matter. Just now we have seen this. Between skull vault and dura matter, whatever hemorrhage is happening, that is EDH, extradural hemorrhage. Now mechanism of action for the extradural hemorrhage, my dear friends. First, the trauma at side of head. At the side of head, there will be trauma. Then temporal bone getting fractured. This bone is called as temporal bone. This is getting fractured, my dear friends. Then rupture of the MMA, middle meningeal artery. Then there will be bleeding in the extradural space. The bleeding which is happening, it will form hematoma. And this hematoma is of which shape? It is idli shape, or you can show you like this, biconvex, idli shape or biconvex. biconvex or biconvex, my dear friends. Other than that, EDH is mostly a coup injury, same side. Countercoup is injury here, impact here. Injury is coup injury. Coup injury is injury at the site of contact. If hit is at this side, you will find injury this side. This is coup injury. Countercoup injury means opposite side. You are hitting from this side and you are getting injury at the other side. So this is a basic difference between the coup and the countercoup. Coup and the countercoup, my dear friends. Now, one very important thing which is associated here would be the lucid interval. Lucid interval is a period of consciousness among the two unconscious episodes. Mean after the patient of EDH can present to you. The patient of EDH, if I can show you here, EDH patient can be presenting you with the lucid interval. What is this lucid interval? The time between sane, the person was sane, then in between there is a gap, then he again becomes sane. In between the sane and the sane, there is a period of insanity. When the mental status of the person was gone. For example, he was sane for 4 months, 2 months. Then in the 3rd month, he become insane, and after 3rd month, 4th month, he becomes sane again. So this is called as lucid interval. An investigation of EDH, any head trauma is there if we perform NEET. On NEET, what we are going to see? On NEET, we are going to see the biconvex shape hematoma. And this is coup injury. Means injury will happen on the same side of the impact. Same side of the impact. This is sane, insane and sane. Now my dear friends, if I can show you with the help of diagram, this is EDH, extradural hematoma, EDH, and you can see this lemon shape also we call this. We call this idli shape also, we call this biconvex shape also. Treatment of EDH, how you will treat. And before that I just want to tell you, here is one more rule in this lucid interval. That rule is called as Magnoton's rule. Magnoton's rule. Magnoton rule says if the person is insane during the lucid interval, he is not liable for any crime. But he is sane, then he is liable for the crime. This is Magnoton's rule, IPC 84. IPC 84 is there for the Magnoton's rule, my dear friends. Now we talk about the treatment of EDH. EDH, first we will give the medicines like IV mannitol. Then if it is not resolving from the IV mannitol is an osmotic diuretic. Now the size is not decreasing, my dear friends. Then we go with the burr hole craniotomy for the removal of the clot. My dear friends, burr hole is done where? What is the site of burr hole surgery? The burr hole is done at pterion. Important. The burr hole is done at pterion. This area is pterion. Here, right? This area is pterion. Here the burr hole craniotomy is done. And autopsy finding. What autopsy finding you are going to see? Unilateral hemorrhage which is red in color. If you open the skull vault, you will see the unilateral hemorrhage which is red in color, my dear friends, because blood clot was there, my dear friends. Next type of hemorrhage which we are going to discuss right here, sir, it is SDH. SDH is subdural hemorrhage. The hemorrhage happening right here, if you see the hemorrhage, subdural hemorrhage happening between arachnoid matter and the dura matter. The hemorrhage which is happening between arachnoid matter and the dura matter, my dear friends, is a subdural hemorrhage. And remember, What is the mechanism of injury right here, sir? Mechanism of injury, if we talk about, sir, there is an intense shaking of the head. Most commonly, intense shaking of the head will lead towards a rupture of bridging veins. It will lead to rupture of the bridging veins. And types can be acute, subacute and chronic. What are the different type of injuries we are getting, sir? Acute, subacute and chronic. If I talk about acute, acute would be few hours to 3 days, and subacute SDH will be 3 days to 3 weeks, and chronic SDH is after 3 weeks. So acute, subacute, chronic. Acute SDH few hours to 3 days, subacute SDH 3 days to 3 weeks, chronic SDH after 3 weeks. Clinical features. The patient will be confused. Mental confusion is there. If there is a case of SDH, mental confusion would be there. Plus drowsiness would be there. Paralysis on the opposite side. If SDH is happening on the left side, my dear friends, the paralysis will happen on the right side. Pupil dilate on the same side of the injury. If the head injury is on this side, you will see the pupil dilatation is on the left side only. Left side only, my dear friends. Again, if I ask you the investigation of choice, your investigation of choice would be what, sir? Here, NEET of the brain. Now, on NEET of the brain, you are going to see sickle shape hematoma. Sickle shape hematoma. Now you need to do the surgical decompression. Treatment is surgical decompression. If I can show you this right here, sir. This is sickle shape. You can observe right here, sir. This is sickle shape or this is banana shape. This type of hemorrhage is happening because of middle meningeal artery damage. This is happening because of the bridging vein, my dear friends. Now coming to the next one. Next is subarachnoid. The third type of hemorrhage what we are going to study, sir. Subarachnoid hemorrhage. Subarachnoid hemorrhage, there will be a rupture of Berry aneurysm. This Berry aneurysm is near circle of Willis. So remember, what are the clinical features you are going to get here? The clinical feature you are going to get here is most severe thunderclap headache. This is a key word you need to find in your exams. Most severe is thunderclap headache. There is a sudden loss of consciousness, might get seizures. If subarachnoid hemorrhage is there will be a sudden loss of unconscious, can be a seizure, because there can be a hypoxic ischemic encephalopathy which is leading to the seizures. Then there will be a photophobia. The photophobia is sensitivity towards the light. The person is afraid when he sees the light. There will be complaint of severe headache. Plus, sometime patient would be presenting with what, sir? Your projectile vomiting. Projectile vomiting, my dear friends. Now, on lumbar puncture, you will see there will be a blood-stained CSF. Blood-stained, xanthochromia. That means blood-stained CSF you are going to get here because traumatic cause is there. Treatment, if we talk about treatment, endovascular coiling or clipping of the aneurysm we have to do. Because Berry aneurysm is bleeding and you have to stop the bleeding first. That is the endovascular coiling sometime we do, and also we use a clip to just ligate the vessels. Now another thing which we are going to discuss right now, sir, is a punch drunk syndrome. Punch drunk syndrome is most commonly seen in the boxers. Boxers are most common, otherwise in the alcoholic patient who are fighting, in them also you are going to see the punch drunk syndrome. So what is the mechanism or mode of injury? Repeated blows to the head. There is a repeated blows to the head, thun. there will be minor, or you can say the boxer's hemorrhage happening. Then it will lead to the punch-drunk syndrome. Repeated blows are happening, then it will lead to the bleeding inside the head. What symptoms? What are the clinical features? Short-term memory loss. You will get a patient in the OPD. You are asking which sports you play. Boxing. My dear friend, short-term memory loss. Mood disturbed. Disorientation. How to check disorientation? You ask, where are you? Time, place, date. Where are you? Where are you? What is the time? What is the date? These type of questions you will ask just to check the orientation of the person. And this person will be disorientated. Then Parkinson's-like feature. What is Parkinson's-like feature? You will say slow movements. Bradykinesia will be there. Slow movements will be there. Slowly, like Parkinson patient. Tremor will be like this. Slowly walking with the tremors. So these are the features you are going to see in the punch-drunk syndrome, my dear friends. Most commonly seen in the boxers. Also seen in the alcohol intakers. Alcoholics. Repeated blow to the head. Minor boxer hemorrhage will be there. Punch-drunk syndrome. Clinical features: short-term memory loss, mood disturbance, disorientation, Parkinson-like features, slow movement and tremors can also be seen. On autopsy, my dear friends, on autopsy, what you are going to see on autopsy? On autopsy, you will see the neurofibrillary tangles. These tangles are also seen in the Parkinson's disease. That is why you are going to see the tangles present. Neurofibrillary tangles can also be seen in such patient, my dear friends. Thank you so much.